Don't forget to mute your gadgets, he said as he's doing it now. If you have any papers for us, they go to Mr. Curran. Madam Clerk, will you please call the roll?
Bell. Curran.
Here.
Freeling.
Present.
Harrison.
Here.
Hinkleman.
Here.
Majerick.
Is here.
Ott.
Here.
Pittsburgh.
Here.
Ballround.
Here.
Werfel. Here. Yarborough. Elliott.
Here, and I think she's coming.
Mr. Chair, you have 9 present at this time and 3 absent. We'll watch
Okay,
for them
thank you.
to enter the room.
Minutes from last week.
I'll make a motion that we approve the meeting minutes from last week.
Moved by Pitchford, supported by Volrath. Any discussion? All in favor signify by saying aye.
Aye.
Opposed sign, minutes, or same sign for opposed, minutes are approved. Requisition review. You're fine.
Good morning. Does anybody have any questions about the requisitions that were, the list that was sent out? Okay, for those of you going to the MAC conference, your stuff is up in your boxes, so make sure you grab that today. And then the report that's gonna be referenced today is actually in your file. So if you go to the G drive while you're in this building, in the commissioner's folder, that's where this is at. So just FYI. Thank you.
And I brought it up easily, so you can do it. Wait a minute, I did the actual movements. It was in my ear. Good, good. I was on directions. My wife.
I don't have anything to say to that. Brian, you want to walk us in?
Sure. So members of the board, today you're going to receive the annual report from WMed. Dr. DeYoung is here. She is going to walk you through the annual report. As a reminder, WMed has been our medical examiner for, this is going to be our second contract since partnering with WMed. You've got a copy of the report. I've asked Dr. DeYoung to really walk you through some of the statistics that tie directly back to substance abuse. So this isn't going to be the most fun topic, but it does tie bar to last week's presentation. So as we go through this, I'm sure that we're going to be bringing up some of the task force recommendations. With that said, there is a lot to get through, so I'll be quiet and let Dr. DeYoung get started.
Thank you, Mr. Doucette. So I am Joyce DeYoung. I think I've met everyone here. I don't believe we have any new commissioners. So it's good. I would like to introduce John Storr, who's with me. He is our Chief Medical Examiner Investigator. John has a big job. As you know, we have investigators that are located in the county and they respond to death scenes. And for all 12 of our counties, John has to make sure that there are, for 24/7, 365, all 12 counties, all the way up to Grand Traverse, that there are well-trained, available medical examiner investigators are available at any time for calls. So, but he's a little new to this position. He's been with the organization for quite a few years, but he thought he'd come around and see how annual reports go, that whole process. So thanks for joining me, John. So I do have, there's some interesting news in Berrien County, and not all of it good, although some of it's a little bit more positive, if you can think about it that way. But we saw a jump somewhat in the number of deaths that were occurring in 2020, starting with the pandemic. The numbers have stayed pretty high in all of our counties. They've not dropped back down. And I don't really know why. Most of the deaths are natural. I don't know why they're not coming back down as things normalize, but hopefully they will. So like I did mention, most of them are natural. Probably the biggest factor, or the biggest thing that we want to talk about are the drug-related fatalities. But before we get to that, I did think it was really interesting that there was a significant decline in motor vehicle-related fatalities. They've all been, it's been like 2019, there were 21, and there were 15, 24, and in 2022, there were just 9. So I don't know what, it's good news. I hope it stays that way. But we did notice a really significant increase in drug-related fatalities, okay, and if you're just looking at accidental drug overdoses, drug-related fatalities, it jumped from 36 in 2021 to 50 in 2022. So a fairly large increase there. We had one of those now, of all the drug-related fatalities, there were 57, six of them were suicides. And so those are, I mean, suicide prevention is a whole nother topic and a whole nother issue. But we had 50 accidental and one that was classified as indeterminate. We classify them as indeterminate when we're not sure if it was an accident. Typically, if it's an accident or suicide, we just can't tell the difference. And but nonetheless, in here we list all of the drugs that were contributing to each one of these drug-related deaths. And if you look through all of them, you're going to find of those 51 deaths, 43 of them had some type of fentanyl in the system. Okay, and there are a lot of different types of fentanyl. I mean, there's I guess you could say plain vanilla fentanyl, but then they also have the parafluoro, and there's a lot of what we call fentanyl analogs that are being produced. They get produced, they're in the system. But we've seen a big increase, and almost all of those are fentanyl related. I see heroin on here once or twice. Heroin used to be in fact, a lot of times when the investigators go out, they'll say, oh, the family says that he was a heroin addict or that, they were addicted to heroin. And we've actually tried to stay away from that terminology just because it's like, probably not. It's probably not heroin. It's a fentanyl. It's a fentanyl analog. And the numbers are increasing. I could look and I could report back to the board to see where we are for 2023, at least for the first half, to see if those numbers are staying high. But my hunch is they are, because they're doing so in all the other counties as well. So it's a really it's a serious problem. It's a critical problem, and I think that it's something that does need, with the monies coming in from the opioid settlements, to look at mechanisms to address this and to treat this. My own personal view is this is a public health issue. I often look at it and think, I don't think we're going to arrest our way out of this, other than diminishing, no disrespect to the sheriffs, like, it's not that you're not doing your jobs, but it's really these are largely public health. And I think that some communities that have done better are the ones that, yes, we have to, if we can, as much as we can stop those distributing the drugs and bring them into the area, that helps. But the actual users, they need different initiatives to treat and to prevent the use of this. I'm not an expert in that. I will say, as far as the office itself goes, we're in a strong position. We're down one pathologist at the time, and there is a severe shortage of forensic pathologists in the country. I'm currently the president of the National Association of Medical Examiners, and items 1, 2, 3, 4, and 5 on our efforts are all workforce related, and trying to increase the number of forensic pathologists because of things like all the opioid deaths, and it makes everybody busier. And they're, I should look and see. I don't know how our homicides were. Yeah, those are up too. So we're, in 2019 and 20, there were 8. 2021, there were 13, 18 in 2022. So, and for us as forensic pathologists, that when there's homicides, obviously there's autopsies involved, but then there's court as well. And that puts an additional stressor on our profession. But we have, we're stronger. We have a CT scanner now, which is helping us as well. It makes us more efficient. We can do fewer autopsies because we can do total body CT scans. But I'd be happy to discuss the fentanyl and and any questions or issues regarding that.
Well, it's a good timing, if you can use the word good. We were talking last week about what to do with opioid settlement dollars, and this dovetails with your
Yeah.
presentation today. Does anyone have any questions for Dr. DeYoung? Yes, sir.
Could you help me understand nationally, what is the correlation between dollars put into opioid, whether it's, deterrence or trying to get people not to get addicted to drugs or helping them get out of that cycle? What is the correlation between that and actual reductions in fentanyl deaths and opioid deaths?
That's a really good question. My take on it is that it's multifactorial, like all of that is valuable, that prevention is a really significant piece of this. And in addition, that it's that for the people who use drugs, to try and treat them, but it's a difficult disease to treat, very difficult. But I don't think either one of those can be ignored. But one of the groups said, and I think that you do have a pilot program going at is it the jail or was it? Yeah,
Correct.
okay, yeah, that it is one of those areas where we see people who were using before they got into jail. They serve their term, they're in, and then when they're back out, they go back to using, but they start using at the same level they were using before they went in, and their tolerance is gone. And so we do see a higher percentage in those individuals. But I think that there's just right, that there's I guess the big answer is is you would need both. Yeah.
With the deaths that are happening, you said there's about 50 in Berrien County. Is that direct taking of like fentanyl, or is that being laced with other drugs? And is there any drug that was more prevalent than others that it was laced with?
They're almost always found with some other drug. Sometimes it's pure. I mean, we had this one, the 15-year-old who was just straight fentanyl. But there's often other drugs in there, and the whole list is if you get to your report, if you find it on your G drive, it's yeah, this man will help you. I believe he is. I think Commissioner Allworth is Dave is the IT support for that. So so often it's laced, but other times when I'm looking through the list here, it's just alcohol and fentanyl or pure fentanyl. But there are often times we had one day in Kalamazoo where there were, I think there were like 12 overdoses, and 6 of them died in one afternoon. Okay. And we run the STORM project actually for the state of Michigan out of WMed, where we do a screening on every death that comes through, so we know what substances are there. But we looked, and looking at these individuals too, it appeared as if they thought they were buying cocaine or methamphetamine, and instead, it was laced with fentanyl. And so I think sometimes when I see like methamphetamine and fentanyl, or cocaine and fentanyl, I always wonder, like, what did they think they were buying? But it's a frightening thing. There's no control on that, so.
Questions? Yes, ma'am.
I don't understand. Oh,
Go ahead.
good morning.
Good morning.
I don't understand. Is it a pill? Is it a powder? Is it a liquid? Do you shoot it? I don't know what it is.
Yeah, right. So it's more like, sometimes it's a pill, but sometimes they're injecting it. Sometimes they're snorting it. That would be the most common. I think they can smoke this as well. John, do you know what they're seeing on the scenes? Like, I mean, that's what we're largely seeing is it's a variety of ways. Yep. And sometimes we'll find people, they're dead. The syringe is right there. So it's, it was an injection, but other times it's, you'll find pipes and they're smoking. Yeah.
Is it expensive? Is it not? Kids are doing this?
Well, some kids must be doing this, but I don't think it seems to be more people in their 30s, 40s, 50s. When I look at the ages of the deaths, it is more, yeah, we have a 15 and 19-year-old, the 20s, but then most of them are actually in their 30s, 40s, 50s. We had one 71-year-old with fentanyl, and So some people in their 60s, but yeah, it's more that middle age. Often, it looks to me as if there's probably more of the whites and African American Black, but they're blended through there. I don't see a lot of, we actually don't see a lot of use in the Hispanic population. But it must be somewhat affordable because it's not just, these aren't just deaths of people who have, who have had a lot of money. Yeah.
Thank you,
Um,
Doctor.
Alex, Bob, and then back to show quick.
So when it gets into the body, what is it actually, I'm curious what causes the death?
Yeah,
What-
right.
what-
It's
what's the effect?
it's a respiratory depressant. So their breathing slows. They essentially stop breathing, and so it's because of that they stop breathing, and then without when they're not breathing, obviously that causes this. Yeah.
Just want to follow up to Alex's question. You see, just from some of the rhetoric I've heard around fentanyl, you see that there's a variance. Some people are taking the drug and using it almost recreationally, buying it, but then there are some that have a little bit of it in another drug and they end up dying from it. How does that, can you explain that? Like how you can have a little bit and end up dying, or people could be abusing it and having that effect where their breathing slows down?
Yeah. So it to a certain extent it's dose related, but especially if somebody has not used it. So the chronic users, they actually build up somewhat of a tolerance to that. They don't get the respiratory depression as much if they're using it regularly. But the ones who use this recreationally, it's a very potent substance. And when you say potency, it's like, if you take, the identical same amount of that and morphine, the fentanyl will knock will knock you out, and the morphine will take away your pain. Okay, so it's go ahead, that's fine. So if you're not a regular user and you don't have any tolerance to it, you will more rapidly, you could succumb to it then. So it's that seems to be the problem. Mm-hmm.
Anyone else? Okay, well, we
All
really
right.
appreciate you making the trip,
You bet.
and
If you have any other follow-up questions or whatever we're, looking at, just, as you go through your opioid settlement funds, if you, need more information, we have a grant from the state that actually, we have one person who full-time is just analyzing all of our drug-related data, and they, we'll probably distribute a report pretty soon from her that gives you a lot more depth on every one of these deaths. So we'll do that. There was one other thing I wanted to mention too, that we just were renewed. We have an elder death review team in Berrien County. We run it we operate this in our counties that have higher populations, such as Muskegon and Kalamazoo, Calhoun, Berrien. And we were just renewed from the state again, from the Prevent, where we're looking at the care of the elderly in the community, and on occasion, is there abuse or neglect that's contributing to their death? And so the state, for the third year in a row, decided that this was a valuable thing that we're doing. So we're going to keep it up. So.
we do have
Yes.
one other
You said
question.
that, just that, when the officers or anybody handling it and die from, if they have a cut or something, is that, have we ever had any of those where it's?
We have
accidental death
not.
from fentanyl, just handling it, or is it all?
No, I think that, I don't want the law enforcement and first responders to be careless, but I think that might be a bit more, yeah, I think I would be more concerned about inhaling, like if some powder's flying around and you inhale it, that would be more of a concern than just the transdermal, mm-hmm. And Commissioner Yarborough, did you have one more question?
Yes, it came to me that when people are donors, they are donating part. What do you all do? Do you notice that? Do you send them somewhere else, or
Oh, if
I
they
mean,
are,
I'm saying when you're doing pathology or autopsy or,
yeah, so like when you say here on here, like the tissue donors and things. on the-
yes.
Yeah,
I just thought of
we have a very close relationship with Gift of Life. And so we're in communication with them. There are certain situations because when the tissue donors are not necessarily a heart or a liver or a lung going out, but they will be taking they'll take skin and they'll take bones and they'll take other things that can be used after these are people who have been pronounced dead. They no longer have a beating heart. And so they'll remove that. But if you have someone that say, was a pedestrian hit by a car and you need to gather evidence off of them before they go to have all of that procedure done, we have close communication with them so that we can get what we need to do done in advance, and then they can go and do that donation. But yeah, we work very carefully with Gift of Life on that.
Thank you.
You're welcome. We're all set.
Yeah, thanks again.
All right, thank you.
Wait, well, Under Sheriff,
Just more comment if I can. Just with, Dr. DeYoung, obviously from the Sheriff's Office and law enforcement, we really appreciate the partnership with WMed and the investigators working with their investigators. So as you look at, obviously it's a contract, we're very happy with.
Oh,
with
good.
WMed.
That's really good to hear. You bet. Thanks. All right, take care.
Thank you, Dr.
All right.
Jean.
You bet.
That's so interesting.
Members of the board, so you're going to be looking through the data and it's fairly bleak, but the timing on today's report was somewhat intentional. Last week, you heard the recommendations from the opioid task force. Today, you heard the opposite side, which is continued inaction will have consequences. You'll just see these numbers continue to climb. My goal is just to remind all of you, you've been supplied with the recommendations from the task force. Take some time, look through the materials that have been presented to you. If you have questions between me, the task force members, members of this board, we will get you answers. But I'm really just calling to each of you, take some time, look through that information from the task force. We will give you time to digest it. We'll give you time to ask questions, seek clarity. But as we move through the fall, the goal is to get the authorizing process underway. As we get into the first part of 24, you have funds that have been awarded from the settlement process. Putting those funds out into the system, following the guidance of the task force is going to be critical. We have a chance here to address a real issue, which is unneeded deaths. So I will just continue beating the drum, look through the information, ask Terry, ask Julie, if you've got questions about the task force. If you need more help, feel free to come to me. I'll get you connected with our health department. We want to be very, very supportive. Okay, I'm off the soapbox.
that does sort of generate a question, at least for me. Do you want the task force to continue? We've received their recommendation, but what are your thoughts? As to Terry and Julie, especially since you're on.
I think one of the recommendations is for it to continue in some form, meeting once every 6 months-ish, or quarterly or something, because it's built up of the experts in the subject matter. But I think the first step is we need to do some kind of resolution saying that we need to move forward with the recommendations with the RFP process. And then the RFP process, that's really the first function of the task force, is to start that review of any RFPs that come in. Now, those RFPs that come in, the recommendation from the task force is that they would review them, make recommendations of what came in, and then it's still this board to decide, is that the way we want to move forward? So it's not like if we do this, you're going to be setting aside the ability to say, yeah, we want it to move in that direction, because it's all coming back to us anyway, no matter what the RFPs that come in are. They'll review those, And then they'll help us understand the scoring mechanism so that we see why this is the best way to move forward.
Terry,
I think Julie really hit it spot on. The one thing I would want to clarify is that reviewing mechanism for the RFPs, we've already had that conversation of conflict of interest, making certain that whoever is on that team reviewing those RFPs have not applied for it, that there is no perceived conflict of interest in that way. But truly, the reason that the task force existed is because these are the boots on the ground who are seeing what we just received report on. They are responding to the crisis that we have within the community for substance abuse, opioid use. And so I personally feel like the task force has a purpose past what they've just presented to this board, and reviewing and then making certain that the standards that we've set forward of lowering these numbers for drug-related deaths is really what we're going to be able to look at and to be able to measure and see if there's that benefit that we're hoping to see.
The only thing I would add is if the task force was to continue, I would love to see a empirical and quantitative how the dollars are being used in the community and where you're seeing the numbers decrease. And if you can point back to those dollars that we put out in RFPs actually causing that correlation.
measurables.
Yes.
And I would, to answer that, that's in the findings. That was part of it, yeah.
What about the health board? How does the health board interplay with the task force, if at all?
So the Board of Health could be used as a review and recommendation body. The way that the dollars will flow is going to be a little bit different and a little bit complicated. If we use the Board of Health to offer feedback on the programming, that would then flow through PHS. We are looking at a request for proposal process, which naturally flows through the Finance Committee. I think that there's value in using the Board of Health because I see we will likely have multiple organizations that have participated in the task force likely having interest in submitting proposals to provide actual services, treatment services, or something similar. So we're likely to see some conflict coming in the form of the task force really beat up the question, if you are going to be a bidder, you can't participate in the review process. Using Board of Health could be a cleaner way. We still want to keep individual members from the task force engaged because you've got multiple folks from the medical community actively engaged. They are seeing the cause and effect. So you want to keep those voices engaged, and quite frankly, they're volunteers. It would be appropriate to keep them engaged in the process. The other point to all of you on this is I don't want us to rush, but I do want you all to understand that we are talking about the potential of multiple contracts. You're talking about the potential of multiple bidding windows being opened and then ultimately closed. None of this is going to happen fast. For each proposal that we get, we're going to have to go through a rigorous review. We're going to have to go through a very planned out approvals process, but then you will have individual contracts that have to be reviewed, modified, and ultimately agreed on by all parties. So as you look at this, just understand that this is weeks and likely months of work before a single dollar is being spent.
Bob,
I'm not sure how the health board would fit into that process. And so I think the key is not making it more difficult and convoluted than it more than likely will be. So I think that's probably a topic of discussion, whether they have a desire to be in a different role than historically has been their function.
is there anyone on the health board currently who is also on the task force?
Yes.
Yeah.
How many people?
Maybe. You know,
So
I'd
you've got,
go back and look.
well, you've got Corwell represented, you've got county staff represented, you've got Dr. Rex is represented. I'm just thinking through the Board of Health makeup right now.
Well, let's, this thing's still somewhat amorphous in terms of what it's gonna be going forward. Let's just have a dotted line reporting to the health board through you. And since you're our liaison to the health board, and then maybe we can look at the task force going forward and decide, do we want to keep everyone who's there now, or do we want to transition it to more of a technical review committee? Not a committee that included stakeholders, recipients and such. But we'll keep it going in some form or fashion, if that's the will of the board.
And manageable in size.
Mr. Chair, just one more offer. If anyone on the board is feeling like they just need more time and they need a better understanding of how the funds are intended to work between Guy and the health department staff, they're more than willing to come back and continue a description of the work done by the task force. But Michigan Association of Counties is also engaged in-house staff that all that person does is help counties understand the use of the opioid settlement funds. So to this group, if you've got a desire to get more information, we can easily queue that up. If you want to hear from an outside party that all she's doing is helping local units understand the use of the funds, we can also queue her up. She's been engaged with the task force, but she's also made clear she's willing to come and talk with you. So if there's that desire, if you need more information, just say it.
Julie?
There's 10 of us that from Annette's stuff here that are going to the MAC conference this weekend. And one of the subjects is the opioids.
Is Amy one of the presenters? She's good.
All right, if there's nothing more on that topic, let's move to general public comments. Anyone wish to be heard? Okay, any other business? All right, we'll break then for committees and come back at 10:30.